Thank you. Okay, it's around 12:30. The goal here is to burn through about 9 presentations, starting with Mark on human-centered care, and then when we're done with that, Eric's graciously going to jump on and give us a really interesting presentation that he threw together in the middle of last night, and then we'll synthesize and wrap up. Mark, the stage is yours.
So, full disclosure, this was a rump session that happened when 4 people started talking here in the front of the room after everybody left. It was not a balanced group. 3/4 of it were Georgia Tech people, so there is an override of yellow jacket thinking here. So human-centered care, I'm not sure that we know what it is, but I guess it's not this. As most of you probably already know, the healthcare system of this country has many issues, but none are more important economically than the fact that 3/4 of all healthcare costs now derive from the management of chronic disease. So we're going to use chronic disease as an entree to talk a bit about human-centered care. Back in the Stone Ages, when I was in medical school, I had the great fortune to be trained by a neurologist who had gotten interested in family medicine. I ended up working for him. I was on his faculty for a number of years, and we did a lot of EMR work. And this was his favorite thing to tell young medical students and residents, that you're going to go through your training, you're going to become impressed with yourself, you'll go make a lot of money, you'll be a pillar of the community, and you'll think that because of you, people's lives are better. But in reality, and these are his numbers, there's certainly no study to prove this, in reality it's 95% of what's going to make a difference to people in their lives in terms of their health is what they do when you're not seeing them, when they're out in the community. So that leads to the notion of what is the real healthcare system? Is it what we've been talking about here for the last day and a half, or is it this, the system in which those patients live the 95% of the time that, or hopefully it's a 99% of the time that they're not in the healthcare systems that we think of. They're in a world where they exist as a complex human being with sociology and psychology and behavior issues. They exist within a family that can have a dramatic effect on their views of health and treatment. I could tell a story in that regard, but I don't have enough time, I'm told. I love to tell stories. You guys know that by now. That family exists within a community that has its own views and biases, and there are tremendous regional differences in those views across the country. Just look at the data on obesity and spending and outcomes of healthcare around the country. They're dramatically different. And all those communities exist within our society that has its own views and mores and prejudices about what is health and what isn't health. That's an interesting question. What is health? So that may be the real healthcare system. So I'll give you an example of how that can be actually very clinically significant. I was just at the American Academy of Family Physicians meetings, and the most popular talk there was a talk to 2 family physicians called 10 Things You Don't Know. And one of them was this. The latest research, you know, there's enormous focus on reducing cholesterol, and we spend as a society, I don't know how many billions of dollars, I ought to look the number up someday, on drugs like statins that are now shown to perhaps increase the risk of cancer to reduce cholesterol. And yet the best evidence we have today is that that only reduces the risk of heart attack by about 5% in aggregate. Exercise, on the other hand, reduces it by 50%. The focus of the system isn't necessarily on the right things because we aren't really thinking about the real healthcare system. So where does that have to do with this conference? Well, we felt we have some advice to everyone, including ourselves, based on this thinking. That is, we think about research in this domain going forward. We really ought to think about it from a broad human-centered systems approach. Think about the healthcare system that we just described as opposed to the one you think you're in. And that almost inevitably, I think, leads to the fact that this research, to be effective and to be meaningful and to produce results that actually might work in the real healthcare system, it has to be quite multidisciplinary. So those of you in computing and engineering, get to know the folks in the liberal arts and the social sciences in your institution. Thanks.
well.
So we didn't get this into a slide. And what the presentation that was just given was fantastic, because that's exactly the context in which we discussed our topic. And we ended up framing it as, what would we put in an RFA? Okay, so this is RFA 10, as in we don't expect you to get it out by 09, but 10 XXX. Simply put around the purpose, rather general, but in that context, prevention, management, and maintenance of personal health where it happens, and in enabling new modes of care, a signal that this is actually a place we can have a lot of impact with our innovations, because we're not so much displacing an existing way of doing things or an existing mode of technology, because it's very much filling in a vacuum where there tends to be not much technology and infrastructure. The way in which we want to do this is by actually suggesting that this RFA call for and create a test bed. And what is a test bed? It's a combination of policy, process, people, bits, code, and devices. So that test bed does end up with code that's running, code that's shared, bits that are flowing, devices that are used, and processes that are built around the use of that, of those mechanisms for capturing data, analyzing that data, and so forth. And then the research that needs to go into realizing that test bed, that you respond to this RFA by saying, this is what I'm going to build to enable this kind of, and to contribute to this test bed. The first component of that is a kind of actionable data capture. And so lumped into that is, from the capture of those bits to the analysis and interpretation, and what are you going to action, whether it's you're informing the patient, informing the informal caregivers, informing the formal clinician, that we should be designing our data capture in the context of its analysis and in the context of the actions that will proceed, and that creates a whole cluster of research. There's a workflow integration, that data is being captured in the context of a workflow, whether that workflow is a clinician or that workflow is the caregiver, or that workflow is the person. That there is privacy. We thought about sticking that under something else, but in this context about where it happens, many things happen where health happens. And so the privacy issues about capturing all that peripheral data and how you build that privacy architecture from the outset, particularly because we want to be to enable sharing of this data, not just protection of it. So that makes privacy a challenge and interesting. An architecture that's going to be scalable, that addresses representation, so that disparate developers of components can come together, and that data captured for one purpose can also then feed into an analysis in somebody else's workflow. And two other components that we wanted as part of this test bed, that there would actually be defined research projects with measurable health outcomes, so that while you're going through this process, you don't end up just doing a lot of abstract definition, that you're exercising this in the context of meaningful end-to-end health applications, where you can test hypotheses about whether this and new mode of care that you've enabled is actually effective in a measurable way. And finally, that this same kind of approach can feed into population scale data modeling, which is going to be important for understanding things related to public health and epidemiology, but is going to be as important for making the underlying mechanisms effective, because you've been able to look across population scale, activity classification, or what have you, because you've had that collection of data. So we're proposing that a role be played by the federal agencies to cause a test bed to come into existence that helps to create this vision.
Here, let's just put this over here. You got your little connectivity? They'll take care of you.
keep holding this. I'm Henry Fuchs from UNC Chapel Hill. I'm here to tell you about multimedia integration for process capture and analysis of trauma. I humbly think this was the best breakout session. I was in, somebody else mentioned that also. We really kept on track. We were inspired by this. So here's the problem. We want to improve initially the outcome of trauma care. This was really inspired by Dick Buchholz's comment here in the morning. And as a second scenario, home care for certain kinds of patients, like, say, Parkinson's, elderly patients of Parkinson's, through analysis and abstraction of the multimedia data streams for the critical event capture, for real-time decision-making support, for the communication, documentation, training, and initially and eventually for a long-term process improvement. So the approach is to take some exemplar environment task, select of capture mechanisms, technologies to analyze, abstract, and integrate multimedia streams. We want to look at, ask experts about intelligent semantic annotation with ontologies and markup languages. There's been some interesting preliminary work on this in several places, Carnegie Mellon and Melbourne in particular. We want to look at the level of detail of reporting and the multimedia evaluation, including comparisons with the expert annotations that have already been done in certain studies that have shown marked improvement to the baseline conventional care. The challenge and risk, as Rujan Abaichi would say, scalability. We know how to do certain things in very small, limited situation, to analyze gait, for example, of a single individual in a pristine environment. But to scale up to multiple people with multiple sensors, with capture devices, with situational noise, with lots of other complications, is a significant challenge and a risk. There's also a non-trivial multi-agency funding problem of the collaboration enriches the problem while both supporting basic computer science and the health IT clinical research, and the need for project evaluation based on intermediate outcomes. That is, this is something that is so challenging, we don't think it's reasonable to imagine that we could improve patient outcomes all in one jump. One second. So the test bed would be, say, a trauma bay monitoring with multiple people, and the complications that typically one of the clinicians was saying is similar to the fog of war situations, when there's so much happening and so little time to do it. The other scenario that we want to propose initially is the home monitoring, say, of a single elderly patient with Parkinson's, where we monitor what happens in, say, her kitchen and the activity of daily life. And this is the two scenarios that we talk about and propose to you is that these are good examples of lots of different kind of medical scenarios that may be helped by this kinds of research. And of course, we hope that similar kinds of approaches will help in both these scenarios. Any questions? No, I guess we don't take questions, right? See? Thank you.
The imaging group. You guys ready?
Uh-huh.
Sorry. Is there a plug here to plug into? Well, maybe I'll just narrate here since I can't find the plug anyway. There we go. Thank you. It's fallen down and it can't get up. Let's see if it will stay. I love it when that happens. All right, so I was going to start out by just narrating and waving my hands, but the previous speakers had slides, so you'll get to see the slides I put together. So we we were a small group that really is focused on images. And we've been listening to the discussion the last few days, and I think the common theme going through our mind was the fact that in a lot of the discussions, images were just kind of treated uniformly with every other type of health data. And in fact, our feeling was that images really in many ways are central to a lot of the diagnosis and evaluation of treatment in medicine. And furthermore, they're a very complex object. And so we really kind of started from the premise that images will provide a great deal of information, but at the same time, they're an incredibly complex, diverse data source, and that we should really spend some time thinking about how we might develop tools around images. So just to kind of to think about this, one question is, suppose that any clinician or any researcher in the country had access to every diagnostic image that was ever taken in the country. So you now have access to millions, if not billions, of images at any time that you're looking at a patient or you're doing work in some imaging area. And to give you a concrete example, suppose that you have a patient that you're trying to treat for a brain tumor, and you're going to treat it using radiation therapy. And so the game in town is, how do you treat the tumor? How do you avoid radiating other critical structures that you don't want to destroy with radiation? What if you could take that patient's image, you could query the entire country, and you could say, give me the treatment plans for the 5 to 10 most similar cases in the country, and let me now start from those treatment plans as a way to optimize the treatment plan for this patient. And furthermore, let me look at the outcomes for those patients, and let me see if there's a way I can even build the outcomes for those patients into the treatment plan. In fact, there's work that's going on that's showing that when you can do things like that, you can significantly improve the plan of treatment for people. So that's just one example, but really the question is, you've got this enormous corpus of data. How do you provide a flexible, content-oriented access to that data? How do you go into images and get the information you need out of those images, which themselves have no content whatsoever? And furthermore, how do you present that information to the user that's trying to make use of the information? Yes, presenting the images is one thing, but how do you present the relevant content in those images? So the first piece of this, to my mind, is the question of how do you get a large enough database of images to make this interesting? How do you really build Picasa for MR, CT, ultrasound, and endoscopy? And to some degree, I know this is happening. I know that Google, for example, is very interested in developing such archives, or other organizations doing it. But it's one of the key and essential resources that we really would need to have to even begin this work. The second thing we talked about is, well, so why isn't this really just content-based image retrieval? It's a topic that people have been working on for years and years and years. What's different here? And really what we evolved toward is, the fundamental premise is that there's a language of images. There's a way of describing content in images that transcends a particular application or a particular use of those images. And so really the approach was to say, given a large enough database, can we develop a language, a description of images that goes beyond very simple structures that happen to be useful for a particular application in mind? And on the complementary side, is there a language of information display? Is there a way for users to describe what they need from those images that matches the content that's available in the images themselves? Now, obviously, that information display has to know something about users. It has to know something about capability to absorb information, and so on and so forth. So it's both a technological question and a human factors question. So challenges and risks. Well, clearly, we've been working in images for decades now. So is it really the case, and we get large databases, we'll find new things? And I would argue the proof is already there. Again, if you look at the computer vision community, which has, in the last few years now, had access to databases of millions of images, it has radically transformed the sort of questions that people ask about images and the way people think about, for example, comparing images. When you have a million outdoor images and you want to find a similar image, often just comparing the pixels works as well as trying to describe the content of the images. So it changes the questions you can ask, and it changes the answers that you get. Another danger, are applications too diverse? Is there really a common language? That may be. We're not going to find that out really until we embark on the adventure. There are obviously other things. You have to get people to give up ownership of medical data. we're talking about huge amounts of data. I happen to know Hopkins has consolidated our image data, and I think we have 25 petabytes as of 2 years ago. And that's one hospital in one city in the country. So we're talking about really enormous data. So computation and bandwidth are issues. And I ran out of time to make the test bed slides, but I already gave you one example of a test bed, which is, can you actually develop techniques which are able to query large image databases, look up the associated patient information, and perform treatment planning or decision support for those treatments. And we actually listed several cases where you can actually take that general problem, you can specifically drive it by cancer, by Alzheimer's disease, by brain deformity in young children, all asking essentially the same question. So that's what came out of the images group.
Okay. So I'm Kay Connelly from Indiana University, and we didn't have time to make a presentation, and we had way too many pieces of paper to bring up here. So you get to look at me instead of something else. We were looking at how can we help persuade or motivate people in their everyday lives. And the first thing we discussed was what kinds of things would we want to help persuade them about. And some of the obvious ones that we've heard before are things like chronic disease management. You know, if you have a chronic disease and you have certain things that you need to do to stay healthy, can we help you remember to do those, and can we actually encourage you to have the healthier behaviors? And we discussed everything from people making conscious choices not to adhere, and so that is one kind of persuasion you need, to that people just kind of being too stressed out and busy with the rest of their lives. So there are other kinds of technologies or interventions you might want to work there. We also talked about wellness management, and this is again a theme we've heard throughout the conference. So, you know, can we improve people's diet? Can we improve their exercise and just general kind of preventative things? But then beyond that, you have some other things that you might want to look at. So someone in the group was very familiar with emergency room accidents, and there are certain behaviors that people have that end up, you know, showing up in the emergency room a lot. So there's poisonings, there's car wrecks and not wearing your seatbelts, there's access to firearms, drownings, overdoses, a variety of things that are that are seen a lot in the emergency rooms, that it'd be really nice if technology could somehow help people remember to avoid those certain behaviors. A perfect example, it's not necessarily a computer, but in your car you have the little seatbelt ding 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 to make sure that you actually have it on. And we could really make those even better if people are, if you have weight sensors in your seats, you know people are sitting on the seats. It can keep dinging until everyone's buckled in, not just the driver, how it currently is. And then we also talked about public health issues, so, you know, lead paint, clean water, and things like that, and where technology might play a role there. So after we kind of identified those different areas where persuasive technologies might make sense, we talked about the kinds of information that you might want to sense that may be useful. So you have your traditional medical and health information that might be in your EHR or PHR. And then from a technology standpoint, a lot of people are really interested in getting things like location, because we've learned how to do that really well. But then you have things that are a lot more difficult to actually try to sense. And those are things like behaviors and activities. You know, how much people are sleeping might actually have an impact on their health. How much they're exercising and things like that. And people are starting to look at those, so those are more common. And then you have things like your social network. You know, we've already heard at this conference, at least in a few of the hallway conversations, that depending on what your social network is, you might be more or less susceptible to things like obesity. So can we sense what people's social networks are? Can we sense resources in the environment? So if we're trying to encourage more physical activity and you're about to take the elevator, do we know where the stairs are so that we can indicate if you just walk around the corner and take the stairs, it'd be a healthier thing for you? Can we sense socio and emotional kind of things? So do we know how stressed people are? Do we know what their moods are? And can that have an impact on when we actually maybe make suggestions for certain behaviors? There are things just on the web now that might actually have an impact depending on what you're wanting to do. So kind of the economic status of people might actually impact their health because of stress and other kinds of things. So can we kind of do a lot of this data capture that might not be particular to an individual, but because they live in a certain space, that data actually has an impact on them. And then also just social resources, amount of social contact you have, do you have contact with pets? Do you have, do you go to churches and things like that? So there are a lot of places where we haven't tried to do kind of data capture that we could actually start looking at. And after you think about all those, hundreds of different types of data, how do we actually start making sense of all this data? And we've had a lot of discussion on doing things. Obviously, we could do kind of data-driven data mining and knowledge extraction, but you could also come at it from the other side and kind of model-driven approaches. How do people make changes now? How can we model that behavior so that we can come up with good interventions? How can we do predictions and trends? We had a lot of discussion on kind of the social networks and how we can actually mine the social graph for interesting information that would be helpful. And how we can leverage people's social networks, how you might have misinformation in these social networks. So can you use reputation-based systems to kind of talk about the quality of the information that's there? Lots of trust issues and just, we had a lot of issues there. And then we talked about once you kind of have some sense making, how do you actually present this information in a timely way that is interpretable and can be actionable. And so there's a lot of personalized information, a lot of context-sensitive information, a lot of, do we do visualizations? Do we give narrative forms of feedback? Do we get physical feedback, something that's really tactile because we have different kinds of learning? And so there are a lot of opportunities there. And then we talked about test beds, and the sky's the limit, really. We could do gaming, we could do looking at whole communities, we could look at particular technologies like cell phones, and so there are a lot of possibilities there.
Next group, number 4, home-based family-based care.
Is the connection automatic? Could somebody help me get the screen on? Okay. It went away.
That should be it. Should.
Okay. So I'm here to tell you about a research program that we're extremely excited about. The program is related to home and family-based care. In this, we started from the premise that the majority of care is happening already outside of the healthcare system. It goes back to Mark's graph about what is the real healthcare system, and that family members and friends and other caregivers are already doing a huge amount of work to provide care and support for ill relatives and friends. The problem that we see is how to make the home an effective non-clinical setting for healthcare which interfaces effectively with formal healthcare while supporting the interrelated roles of family caregivers and patients. The approaches that we see for dealing with this problem include figuring out what information is needed by family caregivers and patients in the home, partly through social science research regarding information needs and behavior, as well as better understanding the nature of home-based care and how technologies are integrated into the home. Understanding some of the basics around different clinical care trajectories and pathways and how they might translate into home-based care. For example, understanding what kinds of anomalies might require professional intervention. Also, using machine learning for developing systems that allow people to train systems to make them more effective and tailored to their particular needs. So when there are notifications and the like, that I'll describe later, being able to actually ensure that they respond to the specific needs of family caregivers. We also think that in order to do this, we're going to need more effective sensing systems that would be working in a home environment. Better computational and analysis systems in order to be able to figure out what is relevant and important within the ongoing information that might be produced in a care environment by those sensing systems. In particular, what we felt would be extremely helpful would be some form of ongoing surveillance as coupled with anomaly detection. And of course, that requires understanding what is an anomaly in a particular case. We also felt that there's a huge fragmentation of information that's available to family caregivers and patients currently, and there's a need for some kind of information integration of different forms of records from different information sources, mashups, understandable summaries, etc. We also, though, recognize that care is a very collaborative process and there's a need for improved processes around communication and coordination in family-based care settings. We need some form of notification of anomalies, possibly some form of visual, like video interfaces in terms of monitoring. We also feel that there's a need for virtual presence because often care happens at a distance, and that should take place in the home, the hospital, and doctors' offices, etc., for all stakeholders. For example, family caregivers may not necessarily be in doctors' appointments, but they may actually know more about a particular patient's care than they do. Also, to facilitate ongoing low-stakes contact with healthcare providers, such as via email or other ways of being able to test out problems in care. We also felt that there's a need for information sharing. We recognize that recollection and memory are often very collaborative processes, and we need to be able to ensure that there's care, that there's information sharing across multiple stakeholders in the system to be able to better manage handoffs in care and tracking across disparate settings. That there's a need for automatic documentation or indexing of the information that's being gathered. As well, we see a very strong need for simplification of technologies that are being used in the home. There can be an incredible burden in terms of use for people who, in particular, might not have the time or education or inclination to do so. What are the challenges and risks? The biggest one that we talked about was that we have a very individualist paradigm in healthcare and health law. And often it doesn't recognize that the family is actually a legitimate site of care and family members are a part of a medical team. There's this problem of fragmentation, which we heard a lot about yesterday. Things are happening in different sites, whether in the home or at pharmacies, etc. Also, to be careful that by adding new technologies, we're not exacerbating health disparities. So having simplifying technologies that might reduce health disparities rather than increase them. We also felt that there were cultural issues that might emerge. We had one case where there was a language barrier in terms of different relatives that we talked about. And also different sort of cultural attitudes towards surveillance and things like that could potentially be a problem. We also think that the problem of too many false alarms could possibly inundate or increase the burden for family caregivers. So there's a need to be sensitive to that and really be very careful about computational methods in relation to that. We also felt that there's a very strong need for formal caregiver support of the family-based care so that it is somebody's job to actually be the go-to person if problems were to emerge or to provide education in using home-based technologies, etc. And we felt that another risk that could emerge would be whether by making home-based care more effective and better supported, could we actually have some purposes that are counter to our goals, which might be to increase the offloading of care that's happening. We also felt that what we're really proposing is a new model of care that would require a much more, a greater valuing of the family and home, and that would require new forms of compensation and incentive for healthcare providers to provide that support, as well resistance to change could be a factor. What do we see as demonstrations and test beds for this research program? One is ethnographic studies of care and information work that's taking place in the home already so that we can better design for the environment. There's a need for instrumentation and development of different kinds of tools that might accomplish this work. In particular, we felt for communication and co-presence at the point of care would be one area, understanding that the home is a site of care, and also for multi-party communication. We also felt that it would be useful to try on a pilot basis instrumenting or outfitting intelligent homes to study how those work and what kinds of effects they may have. Also that there would need to be policy work, et cetera, to try to build a new service model on a pilot basis. And once we have some pilot information, to then look at a larger longitudinal observational study that would correlate a new care model with health outcomes. That is our model. Thank you.
So our team focused broadly on assistive technology as well as accessibility for technology. And we had people on this, a small group, but we had a number of people working in this area. So we began with the question of why should assistive technology have a role to play in essentially any major CFP for future health care. Well, we believe it's crucial because it is paying attention to parts of the problem of healthcare that no one else is really paying attention to. So we wanted to make the point that everyone becomes disabled over their lifetime. Disability is part of the spectrum of human life. So we want to contrast this with a medical model where you treat the disease and either the person is cured, and if they're not cured, well, there's no more to be done. We want to create an infrastructure where it's as routine to have assistive technology as, for example, eyeglasses are today. Quality of life is the most important objective of assistive technology, not just curing disease, because again, many of the conditions that we deal with are permanent. You know many of the motivations as the explosive growth in the elderly population with the concurrent increase in physical and cognitive disabilities. There's a rapid growth in diagnosis of autism spectrum disorders, and we don't yet know whether there are more incidents or simply it's now being more fully recognized. Traumatic brain injury after declines from laws with about essentially seat belts starting to creep up again because there are more people with permanent TBI who a few years ago would have died from physical trauma. Then compounding these problems is that many different kinds of disabilities lead to problems of depression and other affective disorders, so there's much comorbidity. And finally, the impact is not just upon the individual's quality of life, but on the family, community, and the nation. And in particular, one can make a very good dollars and cents argument in terms of the economic impact that on the caregivers as well as the persons with disabilities. Why should we focus on assistive technology as computer scientists now? Well, we believe this is really the right moment in time. We have a robust base of knowledge to build upon. Advances in AI, such as machine learning, machine vision, natural language processing, and knowledge representation, can play an important role in advanced assistive technology. Of course, there's work in pervasive computing with getting mobile computing, sensing everywhere, interacting everywhere. Some forms of assistive technology that people are exploring now involve robotics, such as actual physical robotic caregivers or physical or robotic prosthesis limbs. And of course, human-computer interaction is core to the whole endeavor. Now, a number of the other working groups talked about the need to sense and understand human behavior, and indeed that's a core part of assistive technology. So whether you're talking about a system that helps blind people access the internet, where you're having to sense the human behavior of their actions at the keyboard and try to infer their information-seeking goals, to persons in a home, let's say, and you have a system for a person with a cognitive disability, you're trying to infer what kind of things they're trying to do. Are they trying to dress themselves? Are they trying to prepare a meal? But I think one aspect that assistive technology brings forward is the need to interact with the end users. So it's not enough just to say we're going to collect this data and hand it to a doctor or even hand it to a family caregiver. That might be part of the equation, but it's central that it interacts directly with the user. Another reason why it's a good area for research is that we already have a strong core group of connections between computer science and assistive technology, such as through the ACM assets community. So there's, I think, quite a number of people on both sides who speak the same language. Another observation we made is that there are a huge variety of disabilities, and every instance of a disability is unique in some way. So there seems to be an issue of really bringing this idea of personalized medicine to the front in kind of a different way than might be traditionally thought of in terms of biological processes. Nonetheless, despite this great variety in the causes of disabilities, there are common needs, such as completing activities of daily living, access to community resources, making social connections, holding down a job. So it is a coherent area for research where the results can be broadly applied, so by focusing on addressing classes of these needs. Furthermore, we observe that computer science can provide technology that adapts to the individuals and that individual users can adapt themselves. So in other words, it empowers individuals to customize the technology that assists them. So we think the model we're moving towards is like we have now with the iPhone. You need an app for that. You go out and get it, okay? Now if you have, for example, disability with reading, you're visually impaired, yes, you can get an app that's going to be a good screen reader. Another reason why this is a great area for work is that there are extremely low barriers to entry and adoption and lots of immediate needs. So for example, there's a system that called Web Anywhere, created by Jeffrey Bigham, that helps people access, helps the blind access web resources without having to have a local screen reader installed. And it was created from the initial concept to deployment to tens of thousands of users within a matter of months. So more and more we can leverage consumer technology to make these systems cheap and fast. So finally, it's a great domain for computer science research. I think it can drive these fundamental issues across a wide area of computer science. In addition to particular test beds, we really have the opportunity often to evaluate solutions in the real world. And finally, we think it's also great for the field in terms of just attracting new classes of people to computer science.
watching movies.
Well, in case it doesn't work, there's no big deal. So a lot in this conference was about how to use data, and we have this overflow of data. So our group decided how we would use it in case we had it. So our major goal was to how to build and evaluate predictive models, how to make them useful in clinical practice as well as research. And what we found, that there are several calculators, risk assessment calculators on the web. They were results of large studies being done on large cohorts, and we can no longer afford all of that. So how can we use electronic medical record data in an aggregate form, in a high quality form, in order to build these predictive models, and which predictive models would be most useful in clinical practice? So one application that we thought would be very important is that these predictive models would predict what clinicians need at the point of care. So they would display the information in the format and with the content that clinicians need. How can we get that? Well, of course, we need to aggregate a lot of data in terms of contents and as well as in terms of physician use. So thinking about that, we found that a lot of research is needed at the whole spectrum. The spectrum of collecting the data, the database research, knowledge representation research, new algorithms always needed, new approaches to pattern recognize all of that. And a lot of work in human-computer interaction and understand the patterns of use and how we can display the right information at the right time, and over time collect outcomes to see that we've done the right thing. So our group was very brief in terms of recommendations, in which we also think that different groups can work on the same test bed. So from the data-based research, knowledge representation, and then use this data so that other groups can also develop better algorithms, and then yet another group can develop the display in all the human-computer interaction portions, and this all based on information from the EMR. So that's it.
No Mac dongle up here? Okay, we don't need the slide anyway. I was just going to have it up here so I didn't disappoint Susan, but we'll skip it. It's not worth everyone's time for me to connect it. So we started with the problem of looking at trends, and we were looking at the trends of numbers of physicians per 1,000, or more, perhaps more importantly, number of physicians per thousands of elderly people. And extrapolating, we've decided by 2030, there will be minus 342 physicians per elderly person in this country. Based upon that extrapolation, we decided we needed to replace physicians by computers. And by 2030, physicians other than surgeons will be totally superfluous. All right, so what's the problem that we need to solve to, in some sense, replace physicians by computers? And why will the computers do a better job? Medical professionals do what people can do. And essentially that means that when they have a decision to make, they look at only small amounts of data. They look only at features in that data that are observable using the human perceptual system. And they combine features from multiple sets of data using only algorithms that can be executed in the human brain. So for an example that I'm familiar with in the area of cardiac risk assessment, post an acute coronary event, there's several risk scores. One of the most well-used, most well-known, takes 7 risk variables, many of which are continuous, but they first dichotomize them. So they say you're over 65 or you're under 65. Doesn't matter whether you're 30 or 64, you're still under 65. You're either diabetic or you're not, you're either hypertensive or you're not. So an enormous simplification of the initial continuous data. And then the way they combine them is you get 1 point for each of these things, and they add them together. And if the number is greater than 4, then you're at high risk. I'm sure we can do better than that using computers. And so what we talked about was what were the technological obstacles to doing better, not in the cardiac area specifically, but in general. And the proposal we arrived at, not surprising given the people in the room, as usual, was to develop machine learning technology to deal with the kind of data that arises in these situations. One of the things we did talk about is we didn't want to think about this as, okay, I'm a machine learning researcher, I'm going to go off and do what I want to do, but somehow I'll write a paragraph explaining why it's relevant to healthcare. We really wanted to try and understand what was different about machine learning in this context. What we focused on is the notion that almost all of the relevant data is time series data. And it has a lot of properties that are very hard to deal with using current machine learning technology. I'm just going to list a bunch of those properties. Long way to go to solving all of them, but we could probably deal with a few of these. So here are some of the properties that we think make this data set unusual. It's non-stationary, typically, and it's non-stationary at different time frequencies, both long time scales and short time scales. It's typically not regularly sampled. There are poorly defined noise models, particularly if you're looking at data that involves, say, human behavior or medical diaries, which are very common, or clinical notes. Poorly characterized variation between individuals and populations, which means it's a struggle to extrapolate from what you discover about a population to what you'd like to infer about an individual. Not obvious how to do that. The data we have available to us typically has enormous sampling bias. Mostly it's from sick people. The data is typically some combination of discrete and continuous data and multimodality. ECG data, EEG data, blood pressure data, nurses' reports, family reports. How do we combine those? There are an enormous number of confounding variables, for example, interventions. Right in the middle of the data stream, someone suddenly got a bolus of a drug, producing a non-continuous effect on the data. How do you account for that? This relates to the non-stationarity. Often very poorly labeled data or unlabeled data. The data is at multiple time scales. You've got things sampled at 256 hertz, and you've got things sampled once a day. And somehow you have to combine those in your learning. And finally, an enormous set of possible features, which means that either you have to find some way to do dimension reduction or some way to cope with enormous dimensionality. So those are the problems, the technical problems that we think are very important to confront in the area of applying machine learning in medicine. We felt that any research proposal in that area, in addition to defining the technical problems they're going after, needs to talk about how their innovations are going to be tested against real medical data. We weren't particularly interested in just a bunch of theorems. And related to that, we think that it's probably important to make an investment in tools, and we've heard this from many people already, for creating publicly available de-identified data sets of signals, clinical variables, clinical interventions, and outcomes. And in particular, maybe what we need to do is think about the community providing a platform to make it easy for people to do that, including things like, in addition to technology, a model IRB that people could start to work from to try, when they get data, figure out how to make it available. And with that, I'll stop.
Is that the last one? I'd like to remind I've been getting some submissions from people, but other people that have electronic information, let me remind you again to mail it to Erwin or to mail it to me. And if it's easier to remember my email address, which is graham@cs.berkeley.edu, that's fine. So when the organizing committee was planning this meeting, we had a number of telephone meetings. And in one of the telephone meetings, we were talking about how we were going to determine the outcomes, how we were going to capture all of the wonderful conversations we had over the 2 days. And of course, we've had a lot of summaries, we have a lot of material. I'll remind you once more to email me your material. But I said to them, I had been at a workshop once years ago. I can't remember what the workshop was about at all, but at the end of the 2 days, someone stood up and he said, I've been participating, I've been listening for the past 2 days, and this is what I heard. And I said, wouldn't it be nice if we had somebody who could do that for us? And that's how Keith got involved. He doesn't know that. I mean, he's actually helped enormously to facilitate the meeting. But the reason he's here was initially because somebody said, Keith will tell you what it is he heard. So, Keith, please.
Appreciate that. Thanks, everyone. I appreciate you allowing me to interrupt your meetings from time to time, ask some questions. It's been real interesting for me because I spend most of my time on the applied side of the equation, not as much on the research side. And I have been listening and observing and have been trying to glean out some common themes. Actually, I said this morning, I think we covered a tremendous territory in the last 36 hours. I mean, really, a lot of topics were covered, but there were also some topics, surprisingly, that didn't come up, or at least didn't come up as much. And I go to a lot of conferences, and and I certainly read a lot and track the industry and all the trends pretty broadly across the healthcare and life sciences space. And I noticed, for example, that in a lot of the rooms, occasionally I'd hear the word social networking come up. It was reasonably common, but it rarely made it to the research problem that people were presenting out of their group. So it didn't seem to emerge as a key focal point, which is interesting. And I almost never heard anyone say Health 2.0, which is really interesting because in fact, the Health 2.0 conference was just in San Francisco a couple of weeks ago, and there's a conference going on right now in San Diego called TEDMed, and both of these conferences are very much focused on social networking and other forms of web-based engagement, not just with patients, but really multi-stakeholders. So it's very interesting. That didn't come up as much. Wireless, in general, didn't come up as much either. There was one group in particular that was focused on some mobile platforms, but again, not a very important theme here. And I think we all agreed also as a steering committee that largely a lot of the problems being looked at and the solutions that could be implemented were based on sort of what's today available versus major paradigm shifts. So more incremental looks at how things can change. Like if we laid out all the possible pieces we could plug into a puzzle, all the Lego pieces, this is how we might rebuild it, versus throwing the Lego pieces out and changing the paradigm and totally disrupting. I don't think we were as disruptive. That wasn't the goal either, but I don't think there was as much natural inclination to think disruptively in this group, which is interesting because, again, some of the conferences and some of the other groups I facilitate, depending on the crowd, they're always trying to just basically throw the baby out with the bathwater and start anew. And there was a real sense of let's work with what we have here, which I thought was an interesting observation. But I read through all the stuff, and thanks to Erwin and his note-taking, and I just want to walk you through some of the higher-level themes. There was about, at least 8 overarching themes, and then somewhere in the vicinity of 30 to 40 sub-themes that kind of came out across all of them, which, of course, 30 to 40 is not much of a distillation, but let me let me tell you what I saw. So under the aegis of design, you know, there was a lot of conversation about human factors and user-centered design and thinking about the system. Well, in some cases you went down the path of a system, and in others you took a more component view. So, you know, depending on who was having the conversation. I grabbed this one sentence that came out right out of one of yours. I don't recall who, but someone wrote this sentence, the common transdisciplinary intellectual framework. I like the sentence just because it said it was a reminder to me that this is a trans or multidisciplinary approach, and that, you know, there are disciplines not represented here, obviously, and that we shouldn't forget something just because they're not here. And I know that's, you know, that's important. So, and this is in no particular order, by the way. Analytics, again, another major theme here. New granularities of kinds of data, new modeling techniques, new visualization techniques, new reporting techniques. Obviously, analytics is very important. Ultimately, just having information or even turning that into knowledge, if you don't get it into the right hands, you know, the analytical part of the information value chain is very important. So this came up a lot. You can also call this the interpretive part. Interoperability, one of Julian's favorite concepts. You know, interoperability of systems to support decision making. So clearly, we talked a lot about from room to room to room. I heard a lot of conversations about we've got all these information silos. How do we bring them together to make them interoperable, to enable, you know, this person or this stakeholder, whether it's the patient, the caregiver, the physician, make a better decision. Similarly, you know, connecting those silos to support measurement. Now, whether it's performance measurement or it's some kind of biomarker measurement, but, you know, that was another theme. And then, of course, devices and applications and all of the various pieces that can come together to open up entirely new forms of information and an integrity of information that we're not accustomed to, and remove that human element, the manualization of knowledge transfer from devices to data. So collaboration and communication, you know, I grouped these together, and these are not mutually exclusive, of course. Some of the 8 categories overlap, but social networking, a virtual presence, the fidelity and fragmentation information, and knowledge sharing was a really big one. Pretty much every room at some point was talking about knowledge sharing. So I think, and that's a big, big concept. There's a lot that collapses under that. But I think when it comes to the kinds of research we're going to be looking at, I think a lot of it will be about how to capture, share, and, you know, transfer knowledge across the ecosystem. So that's sort of a low-hanging fruit one. Sensing and signal detection, another one that came up a lot. Well, someone, you know, was talking about smart grid, so that was cool. But, you know, there's the connecting of the information. This goes back to interoperability, of course, making sure you actually have the information, then mechanisms to surveil it and monitor it. Then you need context for understanding where that information is coming from, and then, you know, separating out the noise from the information you need to have, and then, of course, some form of intelligence, the interpretive part, the analytical part, to distinguish, you know, well, what am I looking at? And one of the comments made this morning, maybe more than once actually, was, well, let's not worry so much about whether we need it or not. Let's just store all of it, you know, and that's this new generation, right? That point. A quote from Chris Anderson that was on the screen about, you know, we'll have to sort of look at the mathematical relationships and then worry about understanding what we're looking at later, right? So I think, but this is very important because the sensing and signal detection, you know, in a vacuum is really interesting, but when you wrap around it infrastructure considerations, which is another slide, but I'll just steal my own thunder, you start thinking about the infrastructure implications of having, you know, pervasive, ubiquitous sensing and signal detection. You know, what do you say, 25 petabytes in one hospital, right? I mean, you think about that, right? I mean, Intel had some interesting POV, points of view, over the years, you know, regarding sensing networks and so forth. And, you know, they had put out this vision, their digital health group, about having all these sort of smart devices and sensing capabilities, you know, around healthcare. For example, sensor networks around your home, or even your parents' home, for that matter, to track their gait as they walk from the kitchen to the living room. If they were to stumble or fall, the network could pick up on and detect it for you. But that's neat. That's very Star Trek-y. But you think about all of these devices collecting and sending information to some black box sitting in some data warehouse, you know, data center somewhere. That's you know, and then you multiply that across millions of people. It's a staggering amount of information. We have no infrastructure to capture that. Even worse, if that information is actually intended to go towards a physician's office, which is already a problem in terms of information overflow. And this is so this is neat stuff. But you know, the rate limiting factor. There are several rate limiting factors to its potential. evidence-based medicine, outcomes, patient-centered. I didn't hear accountability, care organization, some of those nuanced, newfangled terms you hear in Washington a lot as much, but certainly we had a lot of focus on evidence-based medicine and outcomes. Again, very pervasive theme. I didn't hear the word quality as much, which also was interesting, because quality just as a goal by itself, as a design feature, just didn't come up. So a lot of other more tactical terms were used. And infrastructure, and you had asked me the other week that we wanted to make this one of the closing discussion points, and it is, it gets a bit tactical, but it is a very important point, because and on the infrastructure side, I kind of put one that's not entirely infrastructure, but storage, a big issue, having the medical grade network. A lot of the telecommunications companies, I've actually worked with a number of the big telecoms, they're always trying to create this medical grade network concept, and was it Zach who talked about a HIPAA compliant cloud? If we had a cloud somewhere that you could throw data in and pull it out, then it would certainly free up adoption to some extent on the institutional side. We're not talking so much on the consumer side, but scalability, I think that's self-explanatory. But having all these issues addressed, these are not easy to do issues. One of the things that always struck me about the lack of adoption of informatics in general in the industry is this completely naive notion by policymakers in Washington that if they make software free, then that'll solve the problems. And I recall one administration ago when someone declared, we're going to take Vista and we're going to make it free, and we're going to give it away, and that therein's going to solve all the problems. And that just grossly underscopes the barriers to adoption around informatics. The software being free is good. That's a good start, but that's about 10% of the problem. Right? The infrastructure and the policy change, the process change and the change management, and the cultural things, all the other issues, that's really what, those are the much more difficult to explain and difficult to address barriers. And that's true here. And I think I heard that conversation a lot in the rooms, because it's a sophisticated crowd. Often people were talking about the cultural issues and the process issues around this. So I think clearly, and hopefully that will come out to the research proposals that would be part of this. But one thing also, I don't think I heard, and if anyone brought this up, I'd be interested to know, I didn't hear anyone talk about cost. And I thought that really fascinating, because I have never seen a conference where people talk about innovation and don't talk about cost. It's in a practical sense. Look what we're going through with the comparative effectiveness, legislation and that's sitting out there. We're potentially entering an era in the U.S., because they've already entered in Europe. This era of looking at at least pharmaceutical innovation and diagnostic innovation from the perspective of what's the cost versus the benefit, whether we'll pay for it or reimburse for it, and that's typically that's top of mind for a lot of people. So it was interesting in today's conference, yesterday's meetings, it just didn't come up that much. People wouldn't talk too much about the practical fact of whether you can build a system and deploy it cost effectively. And in the area of telemedicine, this has been a huge barrier, because there have been a lot of really neat studies done to prove the effectiveness of remote care and remote intervention. A lot of studies over and over again, the US and Canada and Europe, but inevitably it comes back to that the cost of deploying these systems and the infrastructure to support them, even the call center to answer people's questions, is so high, it just offsets the benefits to at the system level to really broadly deploy this. And that's why I think the VA, which is, I believe, the largest adopter of telemedicine infrastructure in the country, they have maybe 40,000 units deployed, 40, 50,000 units, out of, millions of vets, so it's very expensive. So the cost is, I think it's important when we do think about our research agenda. We might want to think about not just what's possible, what is the art of the possible, but to kind of go to think even a little bit more translational, if I can use that term, about how translating those ideas into more practical, adoptable, innovations for our country. And cost is pretty important in the context of IT these days. So those are the themes that I had gleaned from this. Doesn't mean I covered everything, but that was a lot of it. But let's open it up. Those are my observations. Again, a lot of ground covered. Interestingly, some of the themes that are very hot topics in the industry didn't seem to, permeate the group as much, and that's not a bad thing. I think folks took a really pure, clean slate approach. But I'd like to invite some more discussion. What other topics didn't I cover, or please right up front.
Just a quick question about how to interpret your comments about infrastructure.
Sure.
I heard people talking about two kinds of infrastructure. Infrastructure to actually support care
Yeah.
and infrastructure to support medical research, which could be quite different.
Yeah.
And I think both played a prominent role.
Sure. Sure. Well, you
So,
want?
so the discussion that I actually wanted to have as part of this closing session is infrastructure for research. And in fact, let me broaden the discussion that Keith just invited rather than trying to do it sequentially. One question is, are there big themes that Keith missed?
Yeah. Well, let's make sure the list is complete.
Privacy. Privacy.
Okay.
I think we completely missed the need for the physician and the patient to reach out and touch. No haptics.
Okay.
Okay.
The importance of context.
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 Context. I used the word context in the signal detection, but is that a different context you're using the word context in?
The whole individual patient's own narrative.
Okay. Okay. The context for interpreting.
I had a lot of conversations about how to go about evaluating these systems, and the traditional randomized control trial just doesn't work in this
Okay, so
kind of a context.
New evaluative
Yeah.
frameworks. Okay.
Okay.
Great.
Something around communicating the clinical need and clinical requirements from the side of the technology.
Yeah. So as a design principle, starting with the clinical requirements and working your way down. Yeah. Versus. Yeah. That's fair. That's what we talked about this morning.
I think another thing that I heard a lot of was around care and health being beyond just the healthcare setting, and that health is something that is accomplished throughout someone's entire life.
Yeah, you know, I heard it. I didn't hear as much of it as I thought I would hear. There were one or two groups who were very heavily focused on non-acute settings and out of the box. But you know, it was not the majority, but it was an important theme, for sure.
Sorry I wasn't here yesterday, but maybe it was covered. But the notion that it isn't just individuals and doctors, but also communities that have interest in care at the community level, and that's actually another unit of player.
Yeah, that's good. Up front.
Migration paths from what's going to be deployed under the stimulus to better healthcare information technology in the future.
When you say migration paths, migration of systems?
Yes.
Yeah.
In other words, in the next several years, we're going to see lots of information technology for healthcare being deployed, and none of it's going to do, very little of it is going to be doing what we think is possible.
Well, it's all 90s technology, essentially.
Indeed. And so the question is, how are you going to move from that? Once it's deployed and entrenched, and there's lots of politics and lots of invested base in it, how are we going to deal with the legacy problem that we will face in 5 to 10 years?
I think the thing that I do not see in that sort of list, which is in a way a granular list of things that came up.
Yeah.
But in all the discussions I was involved in, we were really struggling with how we could actually put together several of those things to have a breakthrough in what we could do.
Yeah.
And I think that's been a characteristic which is really key to putting all the disciplines together also.
So when you say breakthrough, like getting back to something I said earlier, I mean, being disruptive, changing the paradigm, using
step function change in effectiveness or value or something.
Yeah.
But that because it really is at this, it is putting them all together as you change process and role, and as then we build out or develop new techniques at those point pieces. But it's the putting it together that was the most challenging parts of the 3 breakouts I was part of.
Yeah. You know, I'm not a beta user for Google Wave, but I read an article on it, and it said the easiest way to describe Google Wave is if email didn't exist before and we designed it today, this is what it would look like. And and I think going into a lot of these meetings today, we didn't have a clean slate. We weren't designing healthcare today. We had a mental model, and our experience, in many cases, decades of experience of how the problems we've solved, and then we've applied some new thinking to that. But we didn't break the mold, and it's a fair observation.
So let me give you the two final challenges. Is there someone, one more comment?
Yeah, go ahead.
All of you who have been up here, and it's been most of you in the last 2 days, will know that there are very bright lights when you're sitting up here, and it's hard to see people who are sitting in the group.
I think it was an important thing which did come up again today, but it's the idea of having some data sets to work with to kickstart some of the analysis people have been talking about. I think it takes more than just perhaps looking around and looking for existing data sets. Most of the data that's around is collected under pretty strong privacy conditions and can't be shared. If we really want to do some of this large-scale data analysis, somebody has to make a big effort and get data that's explicitly gathered with a view to being widely analyzed. It'd have to be cleansed suitably for privacy, but this is a big effort that somebody has to do.
That's a perfect lead-in to the next topic I wanted to bring up. Keith, thank you so much for that summary.
Oh, you're welcome.
And don't go away. And this is directed partly at some of the people in the audience, but some of you may have noticed that we've got a very strong representation of people who are in the government. And they've been participating in our breakouts and in the discussion as other members of our research, our intellectual community. But they're also here because they have an interest in seeing this research agenda carried out. So let me set aside and say I assume that they understand the need for money. But what about the other kinds of infrastructure that would allow us to carry out our research? And John just raised one when he said we don't have the right kinds of data sets. Many of you may have listened to Eric's talk just now with some envy of the access to a test bed to experimental information that he has. So that's clearly one kind of infrastructure that many of you have at least implicitly suggested would be important. What else do we need? What other kinds of infrastructure needs would help to move us forward if they were satisfied? That's one of my questions. All right, let's focus on that. So, Herb, could you go to the mic?
Herb Land, National Academy of Sciences. One of the things that has sometimes come up when I've talked to people about this has been the desirability, not sure it's a precondition, but it's the desirability of what might be called regulatory harmonization. That is, if you have collaborations going, for example, if you have medical collaborations going on between different states, between physicians located in different states, what rules apply regarding liability and so on, and reimbursement policies, et cetera, when states differ in their approaches to regulating and managing practice. And so one question is there technology that might obviate the need for harmonization? That might be a good thing to do. But if there isn't, then is it possible to have ways of harmonizing that regulation so that people at least know the terrain that they're operating in?
So is this part of the research agenda?
Well, it's partly for lack of a better term, it's a policy and research, a policy and legal research agenda. I thought the question that you were asking was what might government be able to do to help facilitate what we're all trying to do as technologists, and I was trying to give you one exemplar of what that might be.
Okay. Rujana.
Yes. Infrastructure is very dear to my heart because I'm an experimentalist. So here is my perception. In order to really, for an engineer, collaborate with medical profession, there are two different cultures. Typically, computer scientist faculty work with graduate students and perhaps postdocs. It's a kind of a bottom-up approach. In order to, in medical schools, typically you have full-time staff people. in order for us to build a infrastructure that will truly collaborate, you know, in the way that we can truly equally work with the medical school, we will need not only support for hardware and all the equipment and sensors and so forth, but staff people. It is the staff people that we in academia suffer in this collaboration. So I would plead for including that when these kind of collaborations are being considered.
A resounding yes to that one.
Other kinds of infrastructure. Bill.
I think it would be helpful if we could figure out how to frame something in this space as massive as the NIH roadmap project was a few years ago. That truly has changed a lot about how research in biomedical organizations is structured and attacked. It has totally changed the relationship between biomedical institutions and their communities. And for the first time, it's taught the deans of medical schools what the word informatics is. And so it really was a cross-cutting initiative that was very broad and that was and had a clearly different end game. How do we dramatically affect the speed of translation? And I think if we could take the kind of multi-agency representation that has come together here and somehow come up with some similarly galvanizing roadmap that would actually let us pull these interdisciplinary connections together much more robustly, we could really change the game.
Could somebody who participated in that say a few words about how it came about, for those of us that didn't participate? Is there anyone? I can't see. Okay, we'll.
I was a part of it, but not a leader of it,
okay.
So I don't think I can.
Okay. Somebody said to me during this meeting, we need to
I would like to make a comment on that. For the
good. Sorry, as I said, it's hard to see. Yeah.
So I guess I can say I represent the engineering school and computational part that take part with the medical school, and we are leading the biomedical informatics part. So I do agree with the what being mentioned is that the interdisciplinary effort really, it has to be promoted, and it also maybe in the center proposal has to be stipulated about the multidisciplinary effort, and also the translational side, because we can build really beautiful systems, but if we cannot validate in the clinical setting and cannot refine it and actually ultimately see that it is being used, then our technology is still in the air. And it might take 17 years to get to it, right? Or maybe it will get lost. So I think that type of effort is really important. And I think everything that we do, we must really take the time to validate that in the clinical setting.
Yes.
Still open for infrastructure comments?
Absolutely, yeah.
Following up on what some people are just saying, I think we could use some organizational infrastructure. I know sitting from where I sit, and when I first got involved in this in a computer science department, I had no idea how to do an IRB and get it through. I had to think about how I could get my graduate students educated about medicine. Fortunately, we had a HST program that some of the students could enroll in, take courses at Harvard Medical School. But some sort of center kind of organization where there's some centers specifically set up to facilitate this kind of research and providing the organizational oomph both for getting research grants out, IRBs out, and especially, I think, for making it easy for students to learn enough about medicine to really contribute.
I think following up on Eva's comment, given that we do need to ensure the clinical utility and value of the things we're talking about in the end, What we need is a comprehensive simulation environment that's just as difficult to construct, with full immersion, with full representation virtually, with modeling of the physical environment as well, so that there's connectivity to the physical environment as part of the comprehensive simulation environment. Because really, there's no other way to study and evaluate solutions unless part of them are simulated and part of them are fully implemented until the whole environment is built out. Otherwise, we're stuck. And then we'll be back in the paradigm of waiting for a complete environment to perform clinical studies, to demonstrate efficacy, and so forth. So I would propose that it would be very difficult to get this done without that.
When Deborah gave her report this morning, she talked about a kind of testbed infrastructure, not quite the same as yours. And she went on to say that there was considerable research needed in order to create that testbed, even though it would then have independent value for other kinds of research. Is that true of the infrastructure you're talking about?
Absolutely.
That's not what she said.
There's absolutely...
It's not what she said?
It's not what she said.
Oh, okay.
Keep going.
Yeah.
And then clarify, please. Yeah.
Unquestionably, there's a lot of research. And really, from much of what we talked about today, it's iterative. So it's very difficult to have high-fidelity, comprehensive simulations, whether they're physical or virtual, because it's so difficult to monitor and record the events that are actually occurring in clinical environments. And because we lack that information, it's very difficult to have a high-fidelity simulated environment. And so simulation tends to be, as was mentioned, and we all know, dumbed down. You know, it's limited to just what you need to get the job done. But as we want to become more sophisticated, our simulations need to be more sophisticated and model-driven. And how to connect model-driven simulations that are partially virtual and partially physical is an area of research. And not only research, but it has to be interdisciplinary, collaborative, and based heavily on systems engineering approaches that are not widely used in this domain, except perhaps for military projects today, as far as I know.
So, 2 comments. The reason I reacted that way is that there's a lot of research that will be needed to realize the eventual vision. But what is amazing about this time is that we can do a huge amount initially in seeding a test bed with things that exist and start to get real data and real experience, and iteratively, which NSF is not the same as incremental, iteratively get to things that are really important and pushing and feeding the research. So that's just why it's not something sequential that you have end PhD topics before you can do an interesting test bed. Let's not do it that way.
Okay, thank you.
Yeah, I do agree with that. I mean, because I think it's really like in a lot of these settings is that when you actually validate that in the clinical setting, you actually feed it back to the simulated models and you actually can look at a bigger system and then you go back. So it is really quite an integrated system in a sense, and it is a continuous process.
I'm Ida Sim from UCSF. I want to pick up on Bill's point about the NIH roadmap, and while I certainly wasn't involved in the genesis of that, but I can maybe give a perspective from on the ground at UCSF how I think it has affected us in the medical world. From what I understand, the NIH roadmap started off with Eli Serhouni wanting to expedite translational research, or research from the bench all the way to the bedside and then out beyond to where our patients are. And that's actually a very expansive vision where the institutes perhaps were looking more narrowly, but this was a cross-cutting vision. And as big as the roadmap was, there were different programs within it. Some of it was funding pioneer awards for individual investigators to be out-of-the-box thinkers. So there were a bunch of initiatives. But I would say probably the initiative in my mind that has been most transformative, and others can agree or disagree, is something called the CTSA. In fact, I wasn't here yesterday because I was at a CTSA conference, and that's Clinical Translational Science Award. And that's a large program that the NIH has, cross NIH, but housed in NCR, National Center for Research Resources, to give money to academic institutions, academic medical centers, to transform the way we train and conduct research. So the notion was that while people were doing bench research, they may not know much about patient care or about how to evaluate an intervention in clinical trials. And similarly, people who do clinical trials in biostats epi maybe don't know what it means to do genomics research. And we need to train people across the silos, but that wasn't going to happen in a medical center unless there was some outside jolt. So this was the outside jolt to the tune of, $100 million that we got at UCSF to transform the way we think about training across the continuum from T1 to T2 to T3. And what that's happened in our institution, at least, is really to bring the enterprise together, the human factors researchers together, the basic scientist researchers together, and it has really established clinical and translational science as sort of a domain of expertise that we're building training and research and support programs across that whole spectrum. And in that context, informatics has gotten a lot more play. I think in respect to what's being talked about at this conference, I think painting the big vision, the equivalent of the NIH roadmap vision, I'm not sure exactly what that is, but it's got to hit the ground somewhere. And I think CTSA, in my mind, is where the roadmap sort of hit the ground, which is how do you affect the way people think and how people are trained and where the incentives for an institution are. I know in my institution, a lot of what's been talked about here doesn't ring. Predictive models, analytics is like, what's that? We need our furloughs, basically. So I think that engagement isn't even going to happen until we have that outside jolt. And so maybe the notion of all these agencies coming together and having a jolt, whether that's centers of excellence or I don't know what it is, but some analog that sort of says, look, we got to think this way, and this is a way to bring people together in a very concrete way. Otherwise, I think we're just going to go around and stay in our silos, unfortunately.
So that's part of where do we go from here. It's an interesting proposal, which I think we need to look at. Do we need...
Just one
go ahead.
Sentence.
Yeah.
There is an analogy to what she talked about
Ida?
in our field as well, as I don't need to tell you that you have the robotics people, and then you have the networking people, and you have the HCI people, psychologists, sociologists, and just as John Guttag was talking about that we need to train, the engineers with respect to the medical, we also have this problem within our own discipline to broaden it, and that takes time and effort, just so that there is a balance between their aspects and ours.
Yeah, Jim.
Just a brief comment. From my experience in Virginia, we have several medical schools in Virginia, but we also have a number of institutions that don't have medical schools that have excellent engineering. And as you're thinking about an infrastructure, I hope you're thinking about ways that to foster the collaboration between institutions with excellent engineering and medical schools, so that I guess the previous comment about needing test beds and interactions with the clinical side and the engineering side, so that those things can be incentivized.
Hi, Chris Johnson, University of Utah. I guess I was printing my boarding pass when the question about if you had any involvement with the NIH roadmap process was asked. I did. I don't know if there was anything you'd like to know about it, but I could tell you something. Also, the comment about the CTSAs I thought was a good one. I'm also part of the CTSA Center program and on the CTSA Informatics Committee. And I know we just had our annual meeting, and I thought I would just tell you some of the summary of the annual report, which was about research networking collaboration facility, informatics education, human studies databases, clinical databases, informatics, IT, computer science synergy, national recruitment registry, data sharing framework. There's a lot of things that we talked about here that they also talked about are important, and they need our help, let me tell you. It is definitely coming from a biomedicine point of view, often from a clinical point of view. There are not that many computer science researchers involved with the CTSAs. There are a few, and a few very good ones, but I think there could be a lot more that we could do together if we got involved and were able to integrate it with our expertise with the NIH's expertise. So I'd love to help with that.
Great.
I wanted to reinforce some earlier points that were made about the funding infrastructure. I personally think that a lot of the work that we've talked about here would fall between the boundaries of NSF and NIH in terms of funding. And I think we need to proactively look at what are those mechanisms that fill that space between, so that we have multidisciplinary review panels, so that we have projects that have a clear home that might be in the space in between, and that we can better support interdisciplinary collaboration.
Anything else? Do we need more workshops? Or do we, I mean, as a community, we seem to have a fair number of them.
So I'm Ted Shortlift from AMIA, and I guess it's important to point out that there are lots of meetings in this field that are not always well attended by computer science, by the computer science community, where there'd be lots of opportunities, I think, for more interchange. I'm not saying that workshops of this sort aren't a good idea, but I do believe that people that have been excited about the opportunities in the healthcare arena from attending this meeting should seriously consider attending, contributing to, and being part of the biomedical computing community that's already very active and has some very good meetings. To that extent, to that effect, I should mention in this hotel in March of 2010 is a 3-day meeting on that we're calling our translational summits our summits on translational science. A couple of days on translational bioinformatics, copied by clinical research informatics, which is the CTSA field that you've been hearing a lot about. So it's basically CTSA-oriented collaborative research activities spread over 3.5 days here in the Park 55. And the big meeting in biomedical informatics that AMIA offers every year is in San Francisco in the Kitty Corner Hotel at the Hilton, starting on the 14th of November. So for those of you from the Bay Area, it's an easy way to come and see what's happening in this community. I think it's true that there aren't a lot of computer scientists in general involved with the CTSA program, but there are a lot of biomedical informaticians involved, and many of them are formally trained in computer science and are really living at that intersection between the two fields and are eager to have more interaction with computer science as well as with the clinical communities. Could I just add one other comment about the CTSAs? I think it goes to the reason that they've worked, because I think Ida nicely summarized the CTSAs, and there may be a nidus of a very good idea there for this community as well. In order to do an established kind of medical research that medical schools have done for some time, namely clinical research, it had become increasingly necessary, and one of those things that medical schools like to say they had, to have something called a General Clinical Research Center, or a GCRC. These were government-sponsored, shared clinical resources in many, many medical schools around the country. I think there were a total of about 100 of them. That have become the basis for almost all outpatient and inpatient clinical research that actually involved real patients getting experimental treatments of one sort or another when you needed to put people on protocols and treat them in a medical school environment. The GCRCs became part and parcel of how a school would actually have prestige and brag about what it could do in the area of clinical research. Under the roadmap that Bill referred to in the previous administration when Zerhouni was the head of NIH, a decision was made first to tax all the institutes to bring more money centrally at NIH, and then to use that money to create a whole new way of doing clinical research that partly was designed to address the issue we've heard several people mention, which is how long it takes to get basic research from the laboratory out into use in the routine clinical setting. That 17-year figure is often quoted, and there are more than one study that suggests it takes at least that long for the best of the new knowledge to actually become standard practice in the community. So he and many others at NIH who were thinking big picture, wanted to do something that would force people to start to realize that it's not enough just to do work in the wet bench laboratory and then to do a few clinical studies in the hospital, of the medical center, but that you had to think about how you move it out into the community and eventually get it into practice in a more efficient way. And they became convinced that one way that was absolutely mandatory for doing that was informatics, that you needed to have the computing and data management infrastructure to do that. So when the CTSAs were announced, there was this requirement that every school had to have a biomedical informatics core in order to get the funding. And furthermore, that if you had a GCRC and you wanted to keep it, you had to get a CTSA grant. That's 100 schools suddenly being told that if you want to keep something that's really important to you, you have to have a better computing infrastructure and an understanding of the academic side of computing in your medical center environment. And the effect on the culture of medical schools has been really remarkable. And I think that's what Ida was referring to. They have changed their way of thinking about this field. There's been a mad scramble to try to get the resources and the individuals that they need in order to actually put together such programs in the medical schools. Because if they don't, they're going to lose their GCRCs, or at least the government funding for them. And that really matters to them. So buried in all that is a kind of lesson, which is, if you can find something that people really care about, and it can be put at risk by failing to take seriously the opportunities to leverage this kind of technology in ways that many of us know makes tremendous sense but have not yet been culturally adopted by the community as a whole, you can have a real impact remarkably quickly. And right now, I think I know right now about 7 new departments of biomedical informatics at medical schools currently being created in 1 year. And that's would never have happened without the CTSA program, which is not about informatics. It's about clinical research and shortening the time from discovery to use in the clinical world. So somehow we may be able to leverage that notion too.
Thank you, Ted. So our time is getting short. Keep thinking about these ideas. Send them to us. We're going to develop some sort of web presence. And people who have some ideas for what they'd like to see there, other than some of the synthesis of the workshop immediately, I'd really like to hear your suggestions of what it would be helpful to have. One of the things that we've already put together that we'll be able to share fairly easily are pointers to other workshops and other conferences that would be of interest to this group. And if you have contributions to that, events that you think other people in this group should know about, send those to us. But please, if you can think of ways, we got a lot done in the last 2 days, and one of the things we got done was actually to cross a lot of intellectual boundaries, to have a lot of people talk to one another who normally wouldn't even meet. And one of our challenges is to hold on to that and to have a community that continues to know one another, trust one another enough to work together. And so any ideas you can suggest would be really helpful. I want to thank all of you for the time that you've put in the last 2 days and for the very active engagement that you've all had in this meeting. I think it's been very successful. I want to thank the organizing committee who did a great deal of hard work. I want to once again thank Barbara Carpenter who did the local arrangements. And I look forward to seeing you all again soon. Thank you.